Came out the road from out of town maybe like 30 minutes ago, so I came running in so I can get on here because I know we had like a little situation going on last time. I can't remember, something was going on. I think some people couldn't access I connect or something, and then I put in the little time frames for you to come in, but it wasn't showing or something. There was something going on, but eventually we got it straightened out, and thank goodness for recordings. So hopefully you all were able to access the recordings for last time. Y'all you couldn't get the link? The link wasn't available. Let me see if I can read some of your. Is that for everybody? Alright, okay. But somebody, let me see, my things are going up so fast. Somebody said they couldn't access the link. Right? Just if you have the issue, you can do a private thing so I don't have to kind of scan through all of the comments. You can send me a private message and we can try to figure out what's going on. So you should be able. Let me hit record. Let me ask for you all to do me a favor. When I come in and we get going and start talking, just always remind me to make sure I press record. Usually I remember, but I always like to tell the students to help me remember that, because if I get through this whole presentation and I haven't pressed record, we won't have a recording. Okay? So let me just ask you to do that. Again, most of the time I remember, but just so have one of those days, maybe a lot has been going on and I'm not thinking like I should, you can help us out. So I'm going to go ahead and hit record meeting now. So we will be okay here, because that's how you get it. So we're good. Alright, yeah, so again, the instruction is if you are able to access the link from last week, Sunday, please just send me a little private message in the inbox here. Or if you're in my class, you can email me. And if not, I can send my email if you're not in my class. But just let me know, because we want you to be able to access that. Other thing, I just was, as I was posting some things on here for us tonight, I noticed you all were mentioning the time. And of course, what I have scheduled is every Sunday evening. It's actually 8:30 p.m. Central Time. But it's 9:30 p.m. Eastern, and I am in Eastern time, so I am getting on at 9:30. But the reason why I used to do it on Monday, but the reason why I'm doing it on Sunday now, because people are working during the week, and so we're on an online class, and people are taking the course from all over the place, different time zones, and the later I can do it Eastern time, that's going to make room for these other time zones. I know 8:30 Central, and I'm not really sure what Pacific and all these other times, plus Sunday is on the weekend. So that's the reason. So all of you all who are Eastern with me, I'm so sorry, because it's late for me too. But I'm really trying to do that to get more students on versus, just getting on the recording. So hopefully everybody kind of, overlook that if if it's a little late for you. And like I say, if you're tired or whatever, that's fine. There is a recording, and you can always listen to that and send questions to either myself, or if you have a different professor or what have you, that's okay. Okay, so it's okay. I'm the only one who is required to be here. You don't have to. All right, you can use the recording. All right, so that's that. The other thing I want to point out, and I know this is the second, quote unquote, I guess we could say time we're supposed to be meeting, but it's more like the first, since we didn't meet last time in person, or well, on recording. Notice in the file box, I have some files over there for you. Most of the time, you'll get, I'll send you a copy of, within the file box, a copy of the PowerPoint that I have, that I'm speaking from. Tonight, I actually have two files in the file box, which is the PowerPoint, as well as there is an, if you scroll down, you should see it in the file box, E&M example using 3M encoder. And the E&M is what we're going to be covering for this week. So if you haven't actually looked at what's coming up, you might be like, what are you talking about? But that's evaluation and management is what we're going to be discussing tonight. That's what's covered under Module 2. That will be helpful probably to you. Now, some people, if you try to use the encoder to do your evaluation and management, it can be kind of a little challenging for this type. It might be a little easier when you get into your surgery codes. If it gets to be a little too challenging to do your E&M codes through 3M, then just use your manual, okay? And you might can go back to your encoder for some of your other body systems. All right, but I do have it there for those of you all who would like to try to use it. You can download that for yourself, okay? All right. Now I'm trying to make sure. So my name is Donna Francis Clark. Let me start there. This is week 2. So every Sunday, expect me to come on every Sunday at this time, 8:30 Central. We're gonna do tonight week 2 live lecture, HIT211. Again, I'm Donna Francis Clark. Okay. Week 2. What we are looking at for week 2 in terms of chapters to be covered, like I mentioned, you're going to cover the evaluation and management, which is in chapter, I think that is, my computer is rolling kind of slow. We're doing evaluation and management, anesthesia, and modifiers. And that is chapter, come on, pull down, let's see what we are. I had the book. Chapter 14 is modifiers. Chapter 15 is evaluation and management, E&M services. And chapter 16, anesthesia. That's what the chapters. Now, I kind of touched on modifiers in general. If you listen to last week's recording. But chapter 14 actually goes a little more detail into modifiers. And if you recall from that recording, you looked at some of that information, that the modifiers is what your CBT modifiers as well as HIT211 modifiers. Your CBT modifiers are 2 digits long, and your HIT211 modifiers are usually alphanumeric or all alphabetic characters, but it's also 2 characters. And you apply those to your actual CPT codes, right? To clarify whatever the context of the treatment or whatever services are being provided, the modifier clarifies. Some examples are you have modifiers for multiple services or bilateral services, meaning they're going to do treatment or do a procedure on both sides, right? So it does not change whatever the code you're using to report your services, but it does clarify. And so when you get ready to code, you always want to be questioning when you assigning codes. Is there anything that I can apply a modifier to, or is there anything in this situation that's not, that could use a little more clarification? Become familiar. You're not going to memorize all of your modifiers, but what you do need to do is at least be sort of familiar with what modifiers are available. Okay, so then when you're looking at certain situations, then some of those may come to mind. As well as in your CPT manual, inside cover has a little quick down and dirty cheat sheet of modifiers that you can use. Okay, when you come to live lecture, if you can remember, bring your CPT manual, because a lot of times I may tell you to open up and let's look, like at least eyeball certain things. I don't do it for everything, but certain things sometimes it's easier to comprehend if while I'm talking about it you are actually looking at it. Okay, so on last week I did go through the different sections of your CPT manual. And there are 6 major sections. Some of you, I remember you said you had gone ahead and looked at it. And so there are 6 major sections, evaluation and management being one of them. Okay? With your evaluation and management, I also mentioned this, and I guess I'm bringing a few things from there. A lot of you all, we couldn't make it, you couldn't make it in, but with your evaluation and management, it's different from all other coding sections in your manual. Okay? Basically because all of your other sections, a majority of them are actual surgical procedures. And then, of course, you have like your radiology and pathology and those type of things. But your evaluation and management does not, you don't use those codes for procedures. You actually use these codes for the physician's skills and expertise. Okay, so that's a little different. So I guess if you think about it, these are the codes you're going to use for the physician to get paid for skill sets or the knowledge. They go to a lot of school. Whereas your other codes within your CPT is basically for coding to receive reimbursement for the actual procedures they perform. Does that make sense? Right? I'm going to go ahead and tell you ahead of time, your evaluation and management, at least what I gather from students who come through the course, is probably going to be your most difficult section. All right? Also, with evaluation and management, you're going to probably find when you get into the working world, some of you, I've been looking, I know some of you are already in a healthcare setting. I've read through a lot of your introductions, those who were in my class, but I don't know, have you had any experience with the E&M codes? But a lot of times, especially if you are in an outpatient, that's where your E&M, because CPT, of course, is your procedure codes for your outpatient services. A lot of times, you're not the one who has to really assign the E&M code. Usually, your doctors or your provider will come up with the E&M level. You may have to do some type of auditing type of function or just checking to make sure everything makes sense. But you still are required to understand how we come up with an evaluation and management level, okay? And so what I want to say to you is to not become overly, what's a good word? I don't want to say concerned, but do not become overly agitated or don't get too overwhelmed if you have a little difficulty trying to determine the level. Okay, just give yourself some time to soak it in and try to master it. But as I said, most of the time in the working area, you're not going to have to actually come up with it. Also, they have your automated patient management systems and things like that also can help you to generate E&M evaluation and management levels. Okay, in the working world. So again, do not become overly frustrated. I just say that over and over because once you do that, you kind of shoot yourself in the foot, and we don't want to do that, right? All right. So let's dig in. And again, so this is only focusing mostly on the chapter 15. Chapter 16, I'm not going to really cover tonight because that's anesthesia services. When you read that, that's pretty straightforward. Other than, not other than, but just to emphasize or just to point out, when you're coding for that, that's basically you're not coding for the actual procedure, but you're coding for the anesthesia that's used for the procedure. Okay, there is, and most of the time the provider that codes in this section would be your anesthesiologist. Maybe you've noticed this, if some of you have had surgery or know someone close to you who had surgery and they received their bills. Maybe they were put in the hospital, maybe they had a surgery. The anesthesiologist was utilized. They send their bills separate. Okay? Um, so you would normally get a hospital bill, then you have anesthesiology bills, and they use CPT codes. And you have other things like that, radiology and things like that that you'll notice. If some of you have taken ICD-10 or are already over there, that's where some of that comes in when you're trying to code certain X-rays and things like that, and you would notice that you could not code them if you're coding as a hospital coder, so it makes a difference. This is one of those sections, the anesthesiologists, they code their thing different from, it's not captured in the hospital. All right, does that make sense? So anesthesiology, that's what that is. So when you're getting ready to code out there, again, they use anesthesiology, that's what you would use those codes. And it's pretty straightforward when you see that. So we're going to get down into E&M now. Let's really get into this, and I can show you how it works. Actually, I had a nice sheet that I want to utilize. I just don't know what I did with it. It's going to be okay. Alright, let's move along. Now, if you have questions, you can go ahead and post it. A lot of times, even though what I usually like to do is to take care of, let's see if I can get this where you all can see the whole screen. That probably be helpful, right? Oh, maybe that's too small. I will try, like, if depending on how the flow of my presentation is going, most of the time I'm going to try to answer your question right as we're talking about it, but if it gets to be too many, then I might say let's hold questions to the end, because when somebody's listening to the recording, I don't want it to be hard for them to follow along, if you understand what I'm saying. Sometimes it might be more time appreciative if we hold it to the end, so that people can get through the entire thing. And I'm trying to make this fit all in the screen. I'm having a little bit of difficulty. And it's late, so we can get on with it. Alright. I think you all should be able to see that. So when a lot of times you're going to hear me call it E&M, or in the work field we call it E&M. We don't usually say evaluation and management totally all out. E&M, okay? E&M codes. And these codes start with, for the most part, 99. And so when you see codes written at 99 something, you already know we're coding for physician skill expertise. The name suggests that, because when I say evaluation, think about what that word actually means. When a physician is evaluating a patient, right, they're assessing that patient's medical needs, right? So again, we say in them is skill sets and so forth. That would fall under evaluation, right? And then once they do that, they assess that patient's medical needs. Then that's when management is going to come in. What is management? Once I figure out what's going on with you, then I need to come up with a plan of care, right? So evaluation and management, assessment, skills, expertise in order to treat and care for that patient. All right. Let's look a little bit deeper in what's involved with this. So on the evaluation, the provider is going to identify the nature of the presenting problem, the impact of the presenting problem on patient health, provide a recommendation plan of care for the patient, right? When you think about identifying the nature of the presenting problem, okay, so what that means, so a patient, they're going to come in for whatever the particular reason, right? Whatever the condition, the illness, the symptom, or something. But when I say nature of the presenting problem, I can describe it as, say, if I have a patient that presents with a headache. Okay, we'll do a headache. So the patient presents with a headache. I have another patient that comes in, presents with a headache also. All right, so I have two different patients who come in with a headache. Patient one, once you evaluate that patient, maybe the patient's headache maybe they were laying down, or they were sitting around the house watching TV and they began to have a headache, and they had some sniffles or something, and so that patient, in the context of their headache, they were in the house laying down watching TV, and they weren't feeling well and they got a headache. Okay, patient two comes in with the headache. However, upon evaluation, you find that the patient fell off a ladder. They were up on the roof trying to put some shingles up, and they fell off the ladder and hit their head. Now, although both patients came in with a headache, when we're looking at it in terms of the nature of the presenting problem, which patient probably has a more severe condition, although they came in with the same diagnosis? It would be the one that fell off the roof, right? We're going to be a little more concerned. That's some trauma, right? And so that headache is stemming from trauma. So this is what we mean by the nature of. So you could come in with a problem, you present with a problem, but the nature of it, and two people or three people could come in with the same problem. But when I'm getting the nature problem, that means I'm assessing and that's information, right? And when they come in with the same symptom, I'm going to handle this one a little different. This headache a little different than that headache because it's stemming from something. The nature of it. Does that make sense? All right. So that's what we're going for evaluation. Now, with management, we're going to identify any conditions that may make the patient sicker or cause death, review medical records or test results, prescribe a plan of care. All right. So when we're looking at that patient fell off, roof and thing, when we get ready to manage that problem, providers also look at if this goes untreated, will that patient die? Right? So we're looking at mortality, right? And so if I prescribe this particular treatment plan, will this cause any risk? So sometimes, even when you're looking on commercials and things of that nature, and they tell you, okay, we got this medication for such and such condition, and then before that commercial is over, they're telling you all the side effects, right? So that's also part of the management of a condition, looking at whatever treatment that provider is thinking about prescribing, what are the risks that comes from the treatment itself, all right? And sometimes when you get ready to come up with a plan of care, you may need to pull medical records from past visits, right, to see what situations were going on there, or maybe you got to send them to some kind of lab to get lab work or some kind of x-rays, and so we're going to review the test results so that we can come up with the optimal appropriate plan of care for that patient, right? So this is what the E&M code is representing or indicating. That work, all that work that goes into the visits. Okay? Did y'all already know that ahead of time? Okay. Let's move right along. Okay. Now, let's look at some of the components of how we're going to come up with our E&M code. Okay? So, when we are trying to assign a code for this particular thing, we're going to need to know a couple of things in order to come up with it. You need to know where that service is happening. Okay, so because when I talk about outpatient, there are, when I talk about E&M, there are a lot of different places that E&M can occur, right? So you could be in a medical office, right, home health, there's multiple locations. So you need to know that. The other thing that you need to know is what type of patient that is being treated. And there are two types. You either have an established patient or you have a new patient, right? Established patient or a new patient. Now, the thing about the different categories and subcategories in terms of location of service, so I'm going back, but I'm coming back. I'm going back to location of service to bring in established patient or new patient. So you got different locations. And when I show you in your CPT manual, you will see them. Well, as a matter of fact, let's do that now. So if you have your CPT manual, go to your index, and I talked about how you, if you haven't looked at the recording from week 1, please go back and look at it, because I actually go through the different features of your coding manual. All right, so if you're having trouble. So we're going to go back to the index, which is found in the back, right, and your index is in alphabetical order. You'll see your terms in alphabetical order in the back. Go to evaluation and management. I'm just going to have you to look at something right quick, okay? Flip to evaluation and management. And let me see if I can get to it. If somebody, I have a 2016 coding manual right now. If someone finds the page, you can post the page in the notes for someone else. But if it goes, and you should be in EV. Kind of slow again. Let me see. Right there, page. It's 2015, I think it's one you all need now. Everybody have the same one. Alright, eval. Alright. Okay, I think I'm at it here. Oh, here we go. Alright, so if you're at evaluation and management, and you look down, you're going to see some of the locations. Alright, you see emergency department. Now the other thing, it does locations, but you also see home health, right? Hospitals here, because hospital also has outpatient. Okay, there are outpatient departments and what have you. Okay, nursing facility, but you also see things that are certain types of services that have evaluation and management included in them. So when you see something like case management services, home services, critical care services, it also falls under evaluation and management. So you got some that is going to give you a specific location. Others is a type of service that usually requires a lot more intensive type of E&M evaluation and management, and it's going to require a little more time and effort. So you'll see those also listed under here. Critical care being prime example. But why I went back to show you that is to say, in terms of established patient or new patient, that's not going to be a component of each of those different categories that you see under evaluation and management. So some of them are divided by established patient and new patient, and then you're going to have other areas that are not. Okay? Now, let's look at, you're going to need to know what the definition of a new patient versus an established patient. Now, you probably know in general, but for the purposes of E&M coding, the dividing line is around 3 years. All right? So if it's a new patient, then that patient has not been seen at that provider's office or that group office by another provider in the same specialty in the past 3 years. Does that make sense? I need to repeat that. So if you have a new patient is one that has not been seen in the past 3 years by that particular provider. Now, if that provider is in a group practice, then there's another provider in the same specialty. So, like, if I got a group practice and this particular provider is an ENT doctor, ear, nose, throat doctor, if they have not been seen by that particular doctor, their doctor, or another doctor within that group practice that is also an ENT within the past 3 years, then they're a new patient. So you got a couple things that you got to pay attention to. Past 3 years, right? So if they haven't been in 3 years' time, and then you got to look at the provider who's their doctor, right? What specialty is. Now, if that's the only doctor in the office, then that's straightforward, right? The problem comes in is if they're in a group practice, then you need to pay attention to, because sometimes some of the other doctors will cover, you familiar with that? They'll cover for the other doctor. And in that case, say that ENT is covering for that ENT and they're in the same practice, then that will count. So maybe that patient didn't go to his own doctor, but he went in to the other ENT doctor who's also in that group practice, then that's not going to be a new patient. So then that means your established patient is just the opposite of what I said. That means they have been in within that 3-year period. All right, so everybody has that. So new patient, they haven't received any services or for that provider or another provider of the exact same specialty or subspecialty who belongs to the same group practice within the past 3 years. An established patient is one who has received those services in the past 3 years from that provider or any other provider in the group practice in the same specialty or subspecialty. Alright? And again, in your different locations of services and other services under evaluation and management, not all of them will do new patient, established patient. One example of a section that does is your office and other outpatient. Alright, and that actually the first code you see in your CPT manual. If you call from week 1, your E&M codes are in the very front of your CPT manual. Now we're just in the index, but if you flip all the way to the front of your CPT code manual, go to the first white page. If you recall, in week 1, I talked about your E&M guidelines being in front of each section. So you have your E&M guidelines. Go to the first code that is listed on your white page for evaluation and management, which you should see 99201. Do you all see that? Do you all see 99201? Alright, now notice 99201 falls under what? New patient, right? So we are under office or other outpatient services. We're in evaluation and management. You can look at the code starting with 99. I think there's only a couple of other codes that begin with 99 in our medicine section, but the majority of them, evaluation and management. So you see new patient starting at 99201, and if you flip over, established patient starts at 99211. Right? But you got other categories of services in E&M that do not are not affected by new patient and established patient. You only have some. Okay? Alright. Let's move on. So we got location, the type of patient. The other big thing, this is the biggie, that's going to help determine the level E&M code is the content of service, right? What's all in that service that's being provided? There are 3 key elements you should see there on the screen. You got history, physical exam, and medical decision making. All right, so patient history, when they say the patient history in the document, they're going to document these things in the record. The history is the patient's health before visiting, before coming in, right? Physical exam, the patient's health at the time of the visit, right? The physician will determine, or the provider will determine that. Medical decision making, we call it MDM. It looks at the complexity of the problem, risk, and future health, okay? So those are your three key components. So those are what we're going to look at. Now, there are also other things that can come into play. And again, we're looking at all these things, the location, type of patient, content, service, because these things are what we're going to look at to determine which E&M code we need to use. Okay? So follow with me, because it's going to keep adding layers onto this, and that's when you know, it's going to, okay. Now, so those are your three key components. They're called key components because there are other things that we will need to consider and that sometimes will come into play with your code. Other things to consider: time and the nature of presenting problem. I spoke to you about what the nature of presenting problem was when we talked about the evaluation part of evaluation and management. This is what we mean by nature of presenting problem. The other thing to consider is time. Now, time, sometimes time can become a deciding factor. Let me put it this way. If you still have your code manual open, you might be looking at established patient, or you can look at 99201, and you see some verbiage, the code description there, right? You see some bulleted points there. So 99201, if you look at those bolded bullets, do you see history, exam, medical decision making? Do you see that? In that code 99201. Does everybody see that? Those are three components, right? And if you look at the levels of it, it's history, exam, medical decision making, right? Again, there's certain coding where other things will come into play, but for the most part, this is the thing that is important to determine coding level. Now, if you look under that, you're going to see some narrative right up under those bolded bullets, and it talks about counseling, coordination of care. See, that's what that doctor is doing. You know, sometimes they're going to educate the patient. They may have to refer them to some other doctors. That's what all of that stuff is talking about there. You see it mentions something about nature of the presenting problem. That second little paragraph, I guess you see the first one under the bolded bullets. Then there's another small one that starts with usually. Right? You see that? It says usually the presenting problems are self-limited or minor. Typically 10 minutes are spent face-to-face with the patient and our family. So I'm highlighting that or emphasizing that because that's how much time it probably is going to take if we're going to assign 99201. 99201 is the lowest level for a new patient on your office or other outpatient service, so you make less money. This is a more simplified office visit, right, for a new patient. Now, if you think about it, a new patient versus established patient, new patient is going to be more comprehensive than an established patient, correct? Because an established patient means that that physician is familiar with that patient. So they're not going to have to do as much groundwork to treat the patient as a patient that's presenting for the first time, right? So this usually takes 10 minutes for the 99201. Right? And it's just interesting to mention in terms of time, 99211 for established patient typically takes 5 minutes. Right? So that should make sense. Now, the other thing you need to look at with time. So say the physician is doing counseling, coordination care, and all those things, and say it takes a significantly more amount of time than what's indicated, okay? Then what may happen at that point, because up until that point, before we get to that point, we're just simply going to follow along with when we're signing those codes it should fall in line with what's listed underneath that code. So 99201, 99202, and it can actually as a new patient, the highest code is 99205, right? So that's the highest reimbursement level you can receive. But for whatever reason, whatever's going on, say that provider spends a whole lot more time, or a significant amount of time on counseling, coordination, and care, and those types of things, and the time, let's say that time is 50% greater or more than what is supposed to be spent for that level of service. So if they spend more than 50% or greater, 50% or greater in time doing counseling, coordination, and care, then time becomes the deciding factor. And what I mean by that, for example, say whatever the doctor does their E&Ms, there's the counseling, coordination, care in it, and he determines that the level is a 99201. However, he spends greater than 50% of that time in the counseling and coordination of care. So what does that do? That means even though my documentation supports 99201, I can actually code 99202 based on the time factor. Does that make sense? I'm going to let that sink in just a second. Alright? So again, we're talking about, these are, sometimes you may hear them called contributory components. Alright? And that's when time will make a difference. Greater than 50%. Any questions on that? Do you understand what I mean by that? And that's what I mean where it becomes the deciding factor once that provider spends more than 50% of the time face-to-face with counseling, coordination, and care of the patient. Okay? More than 50% of the face-to-face time. So they're coming in treating the patient, but more time is spent on counseling, coordination, care than that, more than 50%, then you can actually bump up your code level based on time. I just try to say it 2 or 3 different ways. Just put Y in the box if everybody understands. I don't like to move forward too fast if you don't have it. Now, I usually like to take a quick poll. Alright, so do we have it? Right. You can go back and let that sink in. Alright, so now we've looked at all that. So these are the things we need to pay attention to, be concerned with. Now I'm going to go through each of the 3 key components right quick. What's involved in those, okay? So I mentioned the history, right? We flip back here. History, patient's health before visit, right? Now, 3 key components. History, exam, medical decision making. Now, in the history, there are 4 elements that we were concerned with. You got the chief complaint, which is the patient's personal account of what's going on with them, right? So when you come in, what are you coming in for? What's bothering you? I got chest pain. I got a sprained ankle, whatever. So that's the patient's personal account. So chief complaint is coming from the patient, right? Now, then you have history of present illness. You may hear that called HPI, right? We call it by the acronym HPI, history of present illness. What is that? It's the chronological description of the development of the patient's chief complaint. So what happened? What led up to this, right? Does that make sense? History of present illness. What I came in for, what's the history of that particular illness? Review of systems, you will hear that called ROS. Right? Review system, ROS. Guided inventory of patients' organ systems gathered through question and answer. Now, if you think back to when you went to a physician, you ever remember going through a series of questions about different illnesses and stuff that you may have dealt with. That they're getting a review system when you come in that doctor that paper. A lot of times they have it in a form, right? But the thing we want to remember about review systems, because when we get to exam, it may seem like it's the same thing. The review systems is gathered through question and answer, usually in some type of form. All right, or usually they'll do it like when you fill out that initial paperwork. Okay. Then the final is past family and social history. You'll see it written PFSH, and that means basically the patient's background. Their past medical history, their family's history, and I know you all remember seeing that on some of those forms. Where you work, social history is like where you work, are you married, do you smoke, that kind of stuff. So that's the patient's background, okay? Because some of those things can affect what your condition is or how they may be treated, right? So these are all the elements that is involved in the history. Okay? Alright. Move on. Now, I'm going to break down history just a little bit more, right? So we got the 4 elements. On the slide you see here, you only see 3. You don't see chief complaint on here because when we get ready to determine the level, chief complaint is always a component. With some of these elements I'm getting ready to go over with you, they may or may not be in documentation, but your chief complaint is always going to be, right? Because your chief complaint is nonetheless why you came in. So we don't need to worry that. It's a part of the history, but it's inherent to what we're doing. Now, with HPI, history of present illness, right? Chronological description of that patient's condition. There are certain elements that fall under HPI. HPI elements, if you look at the top, the green box, right? I think there are 8 here. And it's location, severity, timing, modifying factor, quality, duration, context, associated signs and symptoms. Now, the way this is done, and if you look over the yellow box, that's your review system elements. If you notice, most of those are body systems, are body areas, right? Body parts. Right? So you see cardiovascular, respiratory, endocrine, psychiatric. The constitutional, that's like patient's general appearance, weight, blood pressure, vital signs, stuff like that. That's constitutional, okay? ENT, ear, nose, throat, and M is mouth, okay? Now, then PFSH, you got 3 elements there. Past history, family history, social history. Now, what we're going to do with those? Okay, so for history, what you're going to essentially do is you're going to need to find, in order to find the overall E&M level, you're going to have to find the history level, the exam level, and the MDM level. Does that make sense? Alright? Once we find the level to each of those 3 key components, that's going to help us to determine the overall level, which includes those 3 key components of those contents of service. Alright? Now let me tell you how you're going to do that. So we're going to start with how we're going to find the history level. We're going to find the history level by determining the level of HPI we have, the level of ROS we have, and the PFSH level. Now you see how this can start to get complicated, right? But let's try to keep it straight. What you're going to do is have your documentation. So usually, if we're going to assign codes, we're going to be looking at our medical record documentation. So when we're reviewing our documentation, we're going to begin looking for, excuse me, these elements, HPI elements. We're going to start with HPI. We're going to look for these elements in our documentation. So, looking, and not all of these may be included, but we're going to look for the ones we can find that they did address. Does that make sense, right? So if I'm looking at location, that probably is one of the easiest. I'm looking for where they document where that symptom or illness is located. So if the patient says they are experiencing left knee pain, then my location is knee. Right? Very simple, straightforward. That also means I have one HPI element that I found. You see what I'm saying? So severity. That deals with, I'm looking at, still, you're looking in your documentation where they talk about how bad does it hurt. Have you ever got 1 to 10, how bad does it hurt? Give it a 9, that's severity. Or you say, the pain is extremely severe. That means you're addressing severity. So then I have 1 for severity. So if I had location and severity that appeared in my documentation, I got 2 HPI elements. Okay? Make sense so far? Straightforward, you think? Okay. Timing, meaning like the pain is constant. That's an example of timing. You know, a constant pain is timing. Then I would be able to count 1 for timing if that showed up. Modifying factor means, have I done anything that makes it better or worse? So, like I took some Advil, and it'll get rid of my headache for a little while, and it comes back. So Advil makes it's a modifying factor. Or even if they say nothing makes it better. It's just a modifying factor. Okay? Quality, if they say very painful. A lot of times with quality, it may have, I'm trying to think of a good example for quality. And that's why I used to have a bunch of examples, so I don't have to come up with them off the top of my dome. Let's see. You know, let me see if I can think of a good one for quality. A bruising pain or a let me think. Let me come up with a good one for you. For quality, it's the type of pain we're looking at. It's a throbbing pain. That's a good one. Throbbing. Usually, a lot of times when you think of quality, it's those words that are very colorful, expressive, like you almost can see it. Anybody can think of another example? Throbbing would be one. A throbbing pain. Some other adjectives. It's like adjectives. You understand what I'm saying? I can't think of another good example. Again, I was looking for my example sheet, and I don't know where it is. If I find it, I'll probably send it to you, list it out to help you out. Okay? So that's quality. Duration is pretty simple. How long has this been going on? 3 days. 1 week. A whole month. Right? If they talk something like that, then you got duration. Alright? Context. When is it happening? My knee pain, it hurts only when I'm walking. Right? So that's context. So don't get context and modifying factors mixing up, right? Modifying factors, what can you do or don't do that affects the pain or whatever the condition is. Context surrounding what does it flare up or what have you, right? When is it hurting? Then associated signs and symptoms. Are there any other things that are going on while that condition you're presenting with is going on? So, say if they come in, they have nausea and vomiting, right? If we're going to go with the vomiting, or what else they can have? Nausea, vomiting, stomach ache. So one of them is going to probably be your main presenting condition. Then the others will be associated signs and symptoms. All right. So what you're essentially doing is looking through that documentation and seeing if you see any of these HPI elements being represented. Now, the thing you need to remember, you only need to find it one time to count it. You don't need to have 3 different examples of duration or something. You only need one, and whichever one you use, that one is going to support that element. Now, what you may find, so when we get ready to look at ROS elements, you're pretty much doing the same thing, but you're doing it for different types of elements. In this ROS, review of systems, you're looking at body systems, right? So if they're addressing the respiratory system, then you can count 1 for respiratory, and so forth. Now, what you may find, because you only can use, if you find one example, you can only use that one example to support one element. The reason why I say that is because I may find something that will support an HPI element, but can also support a ROS element, right? So say if that patient, if I'm going to say they have the nausea, vomiting, and the stomach ache, and I'm going to say the stomach ache I'm going to use to support the associated signs and symptoms, but I could probably also put it under ROS, say under the gastrointestinal. So say you have a situation like that, you're going to have to pick one or the other. So once I use that particular instance to support one element, you cannot use that again to yet support another one. Does that make sense? If it is mentioned twice, then you can use it twice. Now this it sounds simple. You would have to practice because you're gonna have to be able to go through and identify these things and also recognize what will fall under what body system, right? So what I suggest that you do, even before maybe you reach out to your professor, try to see if you can look that up. A lot of the things with coders, we don't necessarily know everything, but we are some darn good researchers, and we have resources, right? So always see if you can find it first. Then if you still are super confused after you think you found, then call them, because when you do it that way, it's going to help you get better quicker versus it being handed to you. Because anything, if it causes me a lot of issue and I finally get it, I usually don't ever forget that. Okay? Well, every time, but do that. So that's how that works. And then PFSH, pretty simple. Past history, family history, social history, you're looking for instances in which they speak about the patient's past history, or say, their mother has diabetes, that's family history. They smoke, or they talk about where they work, or they're married, social history. You only need one to support each one, right? So what we're going to do with that, so now that we did all this kind of counting exercise, what we're going to do with that information, right? And the next question. Okay. Now I know it's 10:29 my time. Now tonight, it may take, certain nights we won't be here as long. The NM is, and I'm not going to hold you all night, but you know what I'm saying, it's a little more lengthy than some of your others. Now look at this chart, and in your book, in your textbook now, and you all have ebooks, I think. I think there's a chart of this nature in your ebook. Okay, and let me also mention, because you all are in the step-by-step, right? We're in step-by-step. On page 434, because I couldn't think of some good HPI examples. If you go to page 434, that's in your chapter 15, they have some good HPI examples for all those who are talking about the location, so forth, duration, quality, burning, throbbing. Look at those, okay? Sharp. So check those out. That'll also help you when you're looking in your documentation. But what I'm looking for, and it talks about how many elements did you count. if you go to page, I'm in your ebook now, not your coding manual. So the other thing I want to mention, I'm going to say coding manual when I talk about the CPT that you're going to get your codes from, and then I say textbook for your ebook. Okay, on page 438, if you flip over there, you're going to see in figure 15.4 a little table to the bottom, similar to what you see on the screen. This is how you're going to determine your levels. Once you have counted up everything, and if you look in your table in your book, you will see history, and it has those three components because chief complaint is already inclusive, right? You got the HPI, and if you look across, so they're going across. Everybody see it? Is everybody in your book 438? Am I talking before you get there? Everybody there? If you go across the HPI, you will have a brief HPI on 1 to 3 elements. You see how you're reading that? And if you look across the entire top in the right, you'll see problem focus, expanded problem focus, detailed, comprehensive. Those are the levels of history, the overall history levels. And so HPI for problem focus history, expanded problem focus history, what you're going to see is a brief HPI, which consists of, you found 1 to 3 elements. You see how I'm reading that? So my chart on the screen is sort of similar. Just look at your chart in the book, because you don't probably always have your book. So then for detailed and comprehensive, if we're looking at HPI levels, you need to at least have an extended, which is 4 or more elements. Right? Then you go to your second row, which is your ROS. On a problem focus overall history, you may not see any. There's no ROS. Right? A problem pertinent ROS means you found 1. So we're talking about those body systems, right? So your documentation only addressed 1 body system. That's a problem pertinent ROS. Extended ROS is 2 to 9 systems. So you found documentation supporting 2 to 9 of those ROS elements are those body systems. That extended ROS will support an overall detailed history level. And comprehensive in terms of your ROS, you have a complete ROS, which is 10 or more body systems being addressed in your documentation. And then PFSH, for your first 2 overall history levels, you won't have any PFSH. For detail, you have a pertinent, which is 1 thing. So maybe only talk about the patient's past history. That will only be 1, right? And if it's 2 to 3, that will be complete PFSH, right? 2 to 3, meaning either maybe they did past and family, or they did all of them, that would be 3. So do you understand what I'm saying? So let me try to bring this in. I'm actually doing this a little different. But so look at the coding shot. Let's look down right below it. This is good. It says when selecting a history level, the choice goes to the lowest level. For example, listen to this. If the HPI is a level 2, right? So level 2 HPI is what, a brief 1 to 3? Do you see what I'm looking at? Level 2 would be a brief, all right? The ROS is a level 2. So if the HPI is a level 2, the ROS is a level 2, but the PFSH is a level 1, then the history level is 1. Another example is if the HPI is a level 3, the ROS is a level 2, and the PFSH is a level 2, then the history is a level 2. All right, and that is in line with the red statement on my screen. Right, the level of overall history is determined by the lowest level of the history elements. So saying that in another way, so it would be nice and cute in a perfect world if my overall history is an expanded problem focus and my HPI is brief My ROS is problem pertinent, and my PFSH is none. Do you see how that neatly falls in that one column that supports the standard problem focus? You see that? But that's not always the case in the real world. So what sometimes you're going to get is when you determine those levels, they're not going to all fall in the stated parameters that are on the table. When that happens, then you need to apply this guideline here. The overall history is going to be determined by the lowest level. So the weakest one is going to determine the overall level. So you may have everything falling under comprehensive, but one, except for one of those history components, and say that one is detailed. Now that makes my overall history detailed because you have to I don't even want to say it that way because I'm going to say that sometimes I don't want to use that term. But just let the lowest level dictate. Let's just put it that way. Does that make sense? I'm going to say, does that make sense a lot? I just want to make sure everybody's with me because I'm going to move on and add something else. So if you're a little shaky here, I don't mind repeating. It's okay, okay? Don't be afraid to say that. Because I'm going to add something else. Alright. Alright, let's look at the next one. We're going to move on. So we got history covered. Everybody, I've shown everybody how we're going to come up with history. Now let's move on. Oh, I got an example. I forgot I got an example. Okay. What is... Now let me read this. We're going to do a quick exercise on how to determine this level. Okay, it says the chief complaint is the chest pain. Patient complains of chest pain, which is what? We got on there the location, which began 3 hours ago. That's an example of duration. Pain has been off and on since that time, with each episode lasting 2 to 3 minutes. Timing. The pain is described as crushing. Quality. There's another quality example. And at times it's rated as an 8 on a scale of 1 to 10 severity. The pain occurs with minimal exertion, context, and is associated with nausea and shortness of breath, associated signs and symptoms. The pain was relieved with sublingual NTG and ambulance modifying factor. Now, what would be the HPI level? So how many do we have? How many do we? Anybody? Let me count. How many we have? Documented for HPI. Alright? Oh, wait a minute. Oh, I'm sorry. I'm up in the wrong part, so you can see, make sure I haven't missed any questions. So this is just for HPI. I'm sorry, y'all. For some reason, I had the chat box up, and I was wondering why. I said, nobody answering. You all answering at the bottom. Okay, so let's see. Sharon, you said, so this is just for HPI, and this is where the number comes in. I forgot what I was talking about then. Now, yeah, this is HPI, right? This is an example of HPI, just to give you some idea of what you're, sifting through the documentation. Just, you know, then you get a feel for it, because you're going to do the same thing with all of them. You lost on a number of these levels. Okay, so look here. So Karen says 8, right? So all you're going to do, so we got location. And this is simple because I've already labeled everywhere it's found. And really, this is showing every example that we just went over, right? Now, in real life, you're not going to have documentation supporting every HPI element. So you're going to count. So all you're going to do, I see location, that would be 1, duration 2, timing 3, quality, that's 4, severity, that's 5, context, that's 6, associated signs and symptoms is 7, and modifying factors is 8. And I got them next to the documentation that supports that element, right? So duration 3 hours ago, that was an example of duration, right? 2 to 3 minutes, that's timing. Crushing, pain, quality, you see that? Alright, so we have 8, and then I think somebody already looked at the level, because I was going to take you back to page 438 on your textbook, and so we know we got 8 HPI elements that are covered in our documentation. So we have an extended, right? So brief and extended is the 2 levels for HPI, right? Your RS levels is problem pertinent, extended, and complete. Your PFSH levels is pertinent and complete. But then all of those support your overall. So everybody understand that? It's kind of just, you know, flowering, I guess we can use. But that's how you count. So you might get your documentation and you only have location and duration that's addressed. Then you only have 2, right? And then that would be a brief HPI. And the same thing will have ROS. You do the same thing like we did here. And once you have how many, you figure out at what level that falls. Then once you get all your levels for all 3, now you got to figure out what the overall level is, which is either problem focus, expanded problem focus, detailed comprehensive. Right? And that's where it came in. If your lowest one is going to determine the overall level. So if your HPI is the lowest, it's going to dictate the level. Now, I'm going to take that all the way back, and I'm actually doing this a little different this time than I've done in the past. And I think I might like it this way better. So it kind of makes sense. If you go back to your coding manual, right, and we were looking at 99201 when we were talking about the timing. Go back to those bolded bullets for 99201. Now, because now it's going to make sense to you. Well, at least the first one, the first bullet. Let me adjust that. The first bullet in 99201 is a problem-focused history. We now know what a problem-focused history is, right? So if you go back to your table, a problem-focused history entails a brief HPI, usually no ROS, no PFSH, right? Brief 1 to 3, right? Or maybe you had 2 that fell on the expanded problem focus and then 1 that fell on the problem focus that dictated it. But what you can see is that 99201, saying a problem focus history, this is going to be a lower level or not, it's a more simple visit. The patient has come in with something that's easy to take care of, more or less. Right? Does that make sense? That's why it's brief. You only got 1 to 3 elements. Usually if something is very severe or severe condition, you're going to have more documentation. They're going to cover more things, right? Which it supports higher reimbursement or higher level code. Alright, so we got that. Everybody with me? Okay. We're going to move on to physical exam. That's what we're going to do. Alright. Alright, so the more problems they have and history, then the higher the level. Yes, usually the more problems they have, the higher level E&M code, which represents higher reimbursement. Yeah, now when you're actually talking about how reimbursement is calculated, I don't know that we discussed this in this class, because I also teach the ICD-10 class. No, it wouldn't be in that class. It's getting late. Alright, so you know I put in I posted in the discussion an example of RBS, RVUs, I mean. Was that this class? Let me look over here. I'm going nuts. I think it's this class. It got to be this class, I believe. What did we talk about in I think it was in week 1 we discussed that. I don't want to tell a story. Let me see. Reimbursement. I think I posted an example of how you calculate. Let me check right quick. Oh, all y'all are not in my class. I'm sorry. Everybody may not be in my class, and I can send you this example. I keep thinking everybody does not come to my class. Yes. So in my class, I had posted an example of how you come up with the reimbursement, because last week y'all covered reimbursement and regulations, and so under your outpatient system, which follows Medicare Part B, which is for outpatient services, you use your that relative value units, right? And I posted the calculation, and so it kind of starts with once you have that code. So if you have a 99201, there the formula for calculating is going to take into consideration the physician's work, the practice expense, and malpractice expense, and then there's a conversion factor that is multiplied with it to convert it to money, right? But those different RVUs that are associated with those 3 different elements, they are dictated by the code that's chosen. So once you choose that level code, then those RVUs are determined, and also your location will make a difference because it takes into consideration geographical area. And then once you multiply, you're going to do some calculations with that. Multiply it by the conversion factor, it gives you the money amount. With that being said, the higher level codes are going to generate higher reimbursement, because that makes sense. They're sicker patients. They're going to have to use more resources, do more treatment services, more evaluation and management planning. So it's more money, right? If you were not in my class and want to see that, just let me know. You can let me put my email address here. You can send me an email, and I can send you that copy of that post. Okay. Sometimes I forget you all are not all in my section. Okay. Let's go to physical exam, which is, now you got to remember, all the way back we talked about the content of service, which is those 3 key elements, right? So we only covered 1 key element, which was history. Now we're going to look at physical exam, right? So your physical exam is a snapshot of the patient's health, requires provider to touch the patient, and it also includes organ systems and body areas. Now this is the one you may get confused with your review of systems, but what you need to think about here is with the physical exam, what makes it different, because they also use organ systems and body systems, that the physical exam is done by the provider, and he's touching the patient and documenting on, this is where you'll see, negative plus this, and patient has such and such, and they'll have all your little body systems listed. Have you looked at your medical record before? So it's a little different than on your ROS, which is usually captured, say, on those initial documents that you fill out when you are going to the doctor. Does that make sense? And if you remember when I talked about review of system, it's usually done by question and answer, whereas your physical exam is done by that provider, that doctor touching the patient, and observing the patient and those types of things, right? Although both of them will use organ systems and body areas, right? So that's how you have to keep them separated. More or less, yes. And usually, you take that up there in the little maybe the medical system, whatever, go over, make sure all that. Usually your art. Sometimes they may send the MA or whoever comes in, the little nurse that comes in first may actually do a question and answer kind of interview on certain things like that as well. But with the physical exam, that's done by the physician. Okay. If you look, if you look on page 440 of your ebook textbook, it shows you the organ systems, body areas, and so forth that are your elements for your exam. And it works the same way that we did your history, right? But physical exam does not have 3 components. You only have to do the physical exam, and that's it, okay? So what you're looking for are these different organ systems, our body areas, and once you do your count, right? Count works the same way. Make sure you read your E&M chapter, right? We can't cover everything, or we'll be here all night. You're going to count, and then you're going to figure out where they fall. Now, the interesting thing about this, now we looked at all history level. If you look at the chart, figure 15.5 on page 440, you got a similar chart as we had in history. The overall exam levels are problem focused, expanded problem focused, detailed, comprehensive. So they're actually called the same thing as the history, but what supports those levels are different, right? So if we look here for a problem focused exam, it's limited to affected body area or organ system of only 1, right? Expanded problem focus 2 to 7. If it's detailed, it's extended 2 to you got 2 to 7 limited, 2 to 7 extended. Let me see that I put that one up here. Hold on a minute. And then comprehensive is 8 or more. It says 2 to 7 limit extended. Now I don't usually see it written like that. Let's see here. Alright, so extended examination is made of the affected body areas and other symptomatic or related organ systems. Expanded problem focus is a limited examination is made of the affected body area or organ systems and other symptomatic or related body areas and organ systems. Detailed and extended exam is made of the affected body areas and other symptomatic related systems. That is, I don't usually see it written exactly like that. Hold on, let me look so I can give you a little more clarification, because that's a little. Let me see how I got it written over here. You'll see a lot, and if you look in the front of your guidelines, they have a little cheat sheet thing right in front of those E&M guidelines in your coding manual. If you hadn't noticed that, you can take a look at those. But I'm gonna okay, exam. Okay. Okay. Okay, so 2 to 7, it still shouldn't affect you too much, because both your expanded problem and detail are 2 to 7. But I need to figure out, for some reason, I don't remember it being just saying limited and extended like that. Either I'm gonna have to look that up, because that's not how I have mine written. This is determined. That's what you're saying. Hold on, y'all. So this is determined what the doctor. Yes, this. We're pulling this from when you go in. Like, so say when you go to the doctor, even if you think about yourself, when you fill out the form, that's your RS. But when you go in and the doctor comes in, and yes, he starts to do his thing. Alright, so maybe he wants to touch your knee. If it says pain, he wants to squeeze. Does that hurt? This is when he's doing his exam, right? Which is not a question answer per se. It's more, he may ask some questions, but he's also observing, looking, and touching different things when you actually go into the actual exam room, right? So that's what we're talking about. He did everyone, alright, yes. So that's how you're going to keep those separate. Also, when you're looking at documentation, now it could be different, but most of the time your HPI file will come first, followed by your review systems and your documentation, and that exam will probably be something coming after that. That's not always the case, but a lot of times you're going to see it that way. Right? Right, and see, the thing about it is there's always exceptions. It's nothing with this, which also kind of lends itself to the coding difficulty, is that there's nothing, almost everything that we'll say to you, there's probably an exception to it somewhere. So it's hard to cover everything that could possibly be the case. So the only thing that'll help you there is just practice a lot, like practice all the problems in your textbook, practice problems in your workbook. Try to get as much practice as you can when you practice problems, because that's going to expose you to different scenarios. That's about the only way I think that that will be of service to you, because there's no way that any coding teacher can cover every single thing that you're going to probably come across. Also, again, be good researchers. Keep your medical dictionary, and your anatomical, maybe some A&P books, things like that. I always encourage students to keep all your textbooks, but these are ebooks. I know some of your books, I don't know which all ones you buy or not, but if you can keep any or purchase some and start your library. You need to keep your those type of things, but really your internet can do you a lot of good too. All right. And I'm going to tell you, you may need to go back and listen to the recording again. This is don't get kind of flustered. Remember, this is your first time hearing this, so you don't put too much pressure on yourself that it needs to sink in right now. This is Sunday, and that's another reason I like to do it on Sunday. Say, go to bed, get up tomorrow at some point, tomorrow evening, whatever good for you, go pull this recording back out, take some more notes. You probably pull, it'll start making sense, okay? So don't fret. All right, listen to it. You can listen to this over and over. Okay. Now, all right. So when you come, so you're only doing for exam. There's no other different areas like it was in history. Once you figure out that level, then that's gonna give you the overall level, right? So that's pretty straightforward. But see, now you're gonna have to keep, because all of this is leading to the overall NM code that you need to select, right? Because if you go back to 99201, you see those 3 bolded bullets on the office of the outpatient, right? You need to be able, you need to know what level each of those key components so that you can get the entire code. So right now we don't have enough information. Now you know how to do your history and your exam. Now the MDM, we're going to get to that, okay? Let's look at MDM right quick. Uh-oh. Oh, wait a minute. I forgot I had this. This might be helpful. So on my screen here, this is pretty much your exam, so I'm digressing just a bit. Let me see it. This may be, let me see, I knew this is the one I was looking at. This is, now I use this one, problem focus, 1 to 5 elements, identified by a bullet, at least 6 elements identified by a bullet is expanded problem focus detailed at least 2 elements identified by a bullet. Okay, let me stop here before I go through these, because see, that's why they're saying the 2 to 7 limit. That's where I was getting thrown off, because mine is set up different here. I usually don't go in y'all book, and I usually don't use this book to do mine. Let me look in your, let me see if they have the, bullet areas. Hold on. I'm looking at your chapter so I can point it to you. I'm gonna let you follow, I'm gonna lead you, don't follow, I don't want you to be, confused, but let me see if I can find, alright, you have your coding manual. Let's see if it's back here. Let's see. Let's see if I can find it. Let's see if your book has it. Let me tell you something about the exam, okay? With the exam, so when you look in your E&M chapter, they're going to talk about the E&M coding guidelines, and there are actually 2 sets of guidelines. You got your 1995 E&M guidelines, and you got your 1997 E&M guidelines. And here's the major difference between the two, because a provider can use either one, but the major difference is with the examination, the one we're looking at now, right? And with the exam in the 1997, the major difference is that you have a general exam, and then you got a specialty exam. And what I mean by that, if we go back to the first code, 1995, that they put out, it only dealt with like a general exam. So if I'm a physician and I'm trying to, and I want to use the comprehensive level, that simply means you got to cover or address quite a number of body systems. All right, does that make sense? But if you are a specialty physician, so general physician, that might not be a problem. But what if you are a specialty physician? Maybe you are a cardiovascular doctor, right? Or you are a ear, nose, throat doctor. At what point do you think you will be able to perform or reach a comprehensive level in terms of an E&M code if I'm only focusing on one organ or 1 or 2 organs? Correct. So the 1997 guidelines, one of the major differences between 1995 is that the 1997 actually has single organ exams. All right. So they don't just have a general exam; they have a single organ exam, which will allow some of these physicians to actually reach a comprehensive level. And what I was trying to find is that if your textbook has the E&M guidelines in it, that's what I was looking for. Because I've seen textbooks that have it. Have anybody even looked at this chapter? Let's see. I'm just looking right quick to see if your book has it. What I might do is also send you that. So y'all notate all this I'm saying I'm going to send you, because if you really want it, I gave you my email, and you can, I like for people to shoot me that email, and say you told me you was going to send me this and that, and then I can respond to it, okay? Please help me out, because sometimes I'm a mess. And I don't see the guidelines in your book, but I sure will get it to you. Okay, well, let's see. Maybe this is it here. Okay. Oh, it does mention it. If you look on page, this is your textbook, page 484 through 486, right? 484 through 486. On 486, it shows an example of a general exam, And when like if you're looking at my screen when I talk about bullets, 1 to 5 identified by a bullet, at least 6 elements identified by a bullet. If you look at figure 15.9 on page 486, this is the bullets it's talking about. So if I gave you a copy of the guidelines, and they actually talk about the guidelines beginning on page 484, but it goes all the way to page 486 where you have figure 15.9. They talk about 1997 and 1995 guidelines. That's what I'm mentioning to you, and it talks about the elements identified by a bullet. Okay, that's what up on my screen, in which I like to use this one. To me, the way I have the levels written out here is a lot easier. But your book that I was pointing to you on page 440. Is also something you can use to determine the level. The one I have is talking about the bullets that are located on that this general multi exam, but they also have single organ too for the 1997, but they only showing you a picture of the general multi, and so that's what I'm looking at, talking about identified by a bullet. All right, you got the 2015 Poli manual. Okay. But your coding manual, it doesn't have them in the coding manual. So I'm actually looking at your textbook, at those pages, and this one I have on the screen did not come from your textbook. So they're doing the same thing. Now, this is called your E&M guidelines. So if you look at your textbook, write down if you don't have your textbook, you look at page, so I'm not confusing you, you need to read over your guidelines. I was telling you it was on the end of your E&M chapter, which is chapter 15. The last 2 or 3 pages, beginning on page 484, it addresses the guidelines. CMS. Yeah. It addresses the guidelines that you're using, and a lot of it affects that evaluate the exam that we're talking about. Okay, and the reason why I brought that up, because what I have on the screen is counted by the bullet. In your book on that I was telling you to look at the chart to determine your overall level, it's going by the body air organ system. So I don't want you to be confused by that. Now you can go ahead and just stick with your table at figure 15.5 on page 440 to determine your levels. So don't worry about using the one I got here, because I don't want to veer from what your textbook has. Okay. But when it mentions bullets, it's talking about those that are like you see in figure 15.9 on page 486. All right, have I lost you all? So you're going to end up coming up with the same thing. So just follow your book to come up with your levels. So your chart in your textbook is similar. The exam chart is similar to the history chart. So just stay on that. Okay. But if you are interested in the guidelines, and it actually tells you right there, CMS, it's on their website, so you actually can pull it up yourself. If you look at the back of page 486, the last page where we're talking about the guidelines, check this out. Oh, it's got articles. I thought it had the guidelines on there. If you have trouble pulling them up, because your AMA, you have trouble pulling them up, I'll pull them up for you. I don't want to worry with it, okay? If you can find them, that's fine, because it should be easy to find, but if you have problems, you got my email, and I will send them to you, okay? So I don't want you to be worried about that. I just want you to practice coming up with these. Plus, I got to get you all out of here. It's already 11 o'clock, so let's speed up a little bit, okay? Yeah, so they have articles. I thought that they had a link there for you on page 46, but don't worry, okay? If you don't find them, ask me. Let me look at the last component so I can get you all out. I don't want you to stay here too long. Now, we're good? Let's look at medical decision-making, MDM. To me, out of all of the ones that you need to determine the level, this is going to be the hardest one. I hate to keep saying something's going to be harder, but I shouldn't tell a lie. But the reason why, okay, so the medical decision making deals with more the management part, right? When we were talking about the risk, how many looking at reviewing records and stuff, that most of that is going to fall under this section or this component. Okay, medical decision making. So 3 parts. Thank you, Melanie. Number of diagnosis and management options, amount of complexity of data to be reviewed, risk of complications, morbidity, and mortality. Those are the components that we're going to be considering for our MDM. Okay. All right. So when I'm talking about number of diagnoses and number of diagnoses and management options, the patient, when they come in, whatever conditions they have are directly are related to management options, because depending on, say if a patient, so let me give an example. If a patient comes in with a cold, right? C-O-L-D, cold. Would you not agree that the options in terms of how we're going to take care or treat that cold is probably simple, straightforward, pretty much laid out, best practices, on what we're going to do about that? That would be considered something straightforward. The physician would not have to put forth too much effort into treating a common cold, right? Versus, say, a patient comes in with chest pain. I like to use chest pain because there could be multiple causes of chest pain, right? And those different causes will trigger a different type of management option. Does that make sense? So, depending on what that patient's diagnosis is, will directly affect how many management options that doctor needs to consider, right? Because if you have chest pain, it could be something coming from your cardiovascular, right? It could be gastrointestinal. It's several different things that can cause chest pain, and so that's why a lot of times if you go in urgent care with chest pain, you know what they're saying? They don't usually they don't treat chest pain. They usually send you on out to the hospital, and a big reason for that is because it could be, the cause of that can range from not so serious to very serious, right? Right, yes. So when ruling out good term, because of that, a number of possible diagnoses, they usually send you on, because if it's of a serious nature, they're not trying to deal with that there. They don't have the resources to deal with that there. All right, so that's what number of diagnoses and management options are referring to. And so you can see, and the more possibilities there are in terms of what that patient is coming in with, the more complex the visit. Y'all still following me? Okay. Now the other one, amount and complexity of data to be reviewed, that kind of follows depending on what type of diagnosis and management options that the physician is dealing with. So if it's something of a more serious nature, then what you tend to see is more ordering of old charts, records,
lab test results. So it usually follows the more complex the condition and the circumstances, you're going to probably see more reviewing of data. Because like that, again, going back to the common cold, if a person comes in with a common cold, what I be calling their other some other what's the word for it? What I be calling their diabetes doctor and some other doctors, 2 or 3 more doctors that patient sees, are when they came in 2 or 3 visits ago, get all those admissions, and I order them and send them to, if I'm the provider and I'm going to go over those for a common cold, no, I'm not going to do that, right? But if it's something of a more serious nature and the type of management option that we're considering has its own set of risks, then you're going to more likely see more data being reviewed, right? Because you want to be very sure, absolutely sure, this is what we need to do, right? So the more simplistic the problem, more or less, you're probably not going to see very much of somebody pulling some data, right? Because I already know, give you some orange juice, take this medicine, get some rest. I'll see you back in 2 days or something, right? All right, so that is amount or complexity of data to be reviewed. Then we look at risk of complications, morbidity, and mortality. Okay, here is where they are considering the risk level. What is how much risk is involved in whatever is going on with the patient? Like I mentioned earlier, if we don't treat this patient, if the patient goes untreated, are they going to die? And if it's more likely they're going to die, that's going to bump that up to a higher level of risk, right? Now, when I say that this area is a lot harder, I'm saying that because if we looked at when we were determining the level of history and we were determining the level of exam, all we had to do was look into the documentation, count those elements up, see where we fall, boom, right? But with MDM, the problem with MDM when you're determining the levels is that they don't have it laid out like that. It's not as obvious. It's a little more wiggle room and things that are left to interpretation. That's never good, right? Never good. And I'm going to illustrate this to you. All right, so look at this. And I'm going to go ahead and look in your book and see where your chart is for your MDM level so we can stick to that. So they start talking about medical decision making in your textbook on page 443. If you go to 444, you see that you have 4 levels for MDM. Straightforward, low complexity, moderate, high complexity. Okay? If you have a straightforward MDM, you have a minimal diagnosis and management option, minimal or none for the amount and complexity of data to be reviewed, and a minimal risk to the patient of complications or death if untreated. Low complexity is a little higher level, a little more risk, right? Limited diagnosis management, limited data to be reviewed, low risk. Moderate is getting a little more serious, right? Multiple diagnosis management options, moderate amount and complexity of data to be reviewed, moderate risk for complications or death. High complexity, you could think a couple of things that could cause you death if you don't hurry up and get in there and get something done, right? So that's extensive diagnosis management options, extensive amount of reviewing of data, high risk to the patient, right? So those are the 4 levels of MDM. Now, if you look at table 15.1 on page 445, it gives you a little more, a little better idea of risk, right? So when it was talking about straightforward having minimal risk, right? Minimal risk is one self-limited or minor problem. For example, like an insect bite. Now, again, as I'm telling you how we're looking at this, do you see how this is not as straightforward and clear? There are some gray areas. And then what also is probably going to complicate this just a little bit for you is that you may need to go and try to beef up your patho A&P type thing. It's going to be documented. So I'm glad you asked that question, Sharon. They have to document it so that it supports the MDM. All right, it should be in the record. Medical record. They usually talk about it. You know what they did. All right. So minimal level, I gave you an example of that. Low, if it's low risk, right? It says 2 or more self-limited or minor problems, one stable chronic illness. For example, a stable chronic illness would be well-controlled hypertension, right? Moderate, 1 or more chronic illness with mild exacerbation, progression, or side effects of treatment, 2 or more stable chronic illnesses, or undiagnosed new problem with uncertain prognosis. Like, so they come in with a lump in the breast. We don't know what's going on. We need to check that out, right? Or an acute illness with systemic symptoms, right? Like pneumonitis. High, it goes through those. You can read those. Let's see. For example, something that poses a threat to life or body function. Acute myocardial infarction is a example, right? Or an abrupt change in neurologic status, a seizure. Those will be high level, right? So the way they're doing it, they give you examples because if you think about it, they're not going to be able to cover every situation. So what they do is provide examples that will fall into those categories, and then when you read your documentation, you're going to have to determine where it falls on that on those levels. Okay. So if you look at the chart on page 446, they got it in a cute chart like we had for our history and our exam. And you have your 4 overall MDM levels at the top: straightforward, low, moderate, and high. And then on the number of diagnosis and management options: minimal, limited, multiple, extensive. Amount of complexity or data to be reviewed: minimum, limited, moderate, extensive. Risk: minimum, low, moderate, high. Okay. Go back to 444, and they laid out what supports those different levels. And I want to do, let's see. And also look under, when you're on 444, you got management options, and it goes into a little more detail about your those 4 different levels we looked on to that chart on figure 15.6. And then it also goes into data to be reviewed, right? At the different levels. It gives you the guidelines. Do you see those? You're going to need to read them. And when you were asking me about that question about how you're going to know what amount of data to be reviewed, if you look at the bottom of 444, right, so say they order a test. It says that it should be documented right there. It says if a test is ordered, planned, scheduled, or performed at the time of the E&M counter, the type of service should be documented. If they're reviewing laboratory radiology, all right, it should be documented. So you may see something, for example, an entry in a progress note such as W or white blood cell elevated or chest X-ray negative is acceptable. Alternatively, the review may be documented by initialing and dating the report containing the test results. So make sure you read those things, okay? Because we're going to have to close out, but just a second. Read that page 444, 44, and 445. Again, I know you probably you feel a little shaky on the MDM, but that's how that's going to be because, again, it's not very, it's not laid out in black and white like our others. You understand what I'm saying? So expect to have just a little trouble with it, but again, maybe have a way to look up different conditions to see how you would categorize it. So it's not as obvious when you're doing the MDM. because we're basically looking at the complexity of the service, and you're trying to quantify it when it's a little more objective, I guess you could say. You get what I'm saying? So it's a little vague. That's a good word. It's a little vague in terms of the direction and your guidelines. Going back to those 1997 guidelines, they just try to give you examples to direct you in the right place. That's all you have. Okay. So it's not me not teaching it to you, but that's just is all it is. Now the only thing you need to make sure you understand here, if you look at the coding chart up under that chart on page 446, similar to the coding chart we had for history, but it says when selecting an MDM level, the choice is the majority. So for example, if the number of diagnosis management options is a level 2, the amount of data is a level 2, but the risk is a level 1, then your MDM is a level 2. Alright, so your management options and the amount that will be reviewed were level 2, but your risk was a level 1, but we can go with a low MDM. So that's different than history, remember? So with history, what we did, it was dictated by the lowest level, but with MDM, it's whichever level has more, right? So if I have 2 out of 3 that's moderate and the other 1 out of 3 is low MDM, then I have a moderate MDM. Does that make sense? Now the good thing about this, again, usually the doctor will give you the level, and you may just be making sure it makes sense and what have you. A lot of times you're not going to have to manually do this, and even if you have to do E&M coding, a lot of times they're going to have automated systems. Yes, but you still need to know how to do it. All right, so basically, again, for the choice is the majority for MDM. So if you have 2 falling in one category, that's going to dictate your MDM. Because you only got 3. Alright, as far as how you determine the levels, again, I'm just going to say 444, 445. Okay. And you got a couple of examples on 447 and 448 that you can look at. Alright. Also, when we talked about the CPT manual, I think there is an appendix that have clinical examples that you can also utilize that try to give you some idea. You remember, in those of you who have already looked at week 1, I talked about the appendices, and there is an appendix that have clinical examples that you can look at too as a guide. I think it's appendix CPT manual. Let's see. Okay, we're gonna get out of here. I keep saying that. I think it's appendix. I think it's appendix H. C. Is it C? Yeah, C. Right, appendix C. Okay. Trying to give you as much tools and resources. Again, if you're not in my class or whatever, just send me your email anyway, because I may find some other stuff to help you out with that. And then I won't have to try to look for it if I can get to you this week. Alright, and so in the red says only 2 of the 3 elements must be met or exceeded to justify the selection of the overall E&M. Alright, so we got that. Alright. Alright, that's all I have here. The only other thing I want to quickly do, unless you have another question about what we just talked about. Do you have a question around that? Well, I want to briefly give you a couple of hints about your but this week you have you got your case cases, your first set of case cases. I just want to say a couple things now, then I'm gonna let you go. Okay. So there are 3 cases. I don't know if you have checked it. And and I'm gonna be very quick because we've been here a long time. I promise you, every week is not this. So your clinical coding cases. So you actually got 3. Wait, what week am I? I gotta be in week 2. We in week 2. You have, if you look at the discussion, you have actually 3 graded discussions there. 2 of them are your regular discussions, like last week, and then you have actually a coding case discussion. Alright, and so when you go to that coding case discussion, you can either access those cases through a little link there in the actual discussion, or you go under lessons and scroll all the way down, it's also located there. So there's always like 3 cases each week. This particular week is going to require you to do E&M, evaluation and management coding. Okay? So here's your first self-practice if you haven't done so already. But now if you got screenshots, you can screenshot them. That's what I do. Because sometimes I like to have I like to have my stuff on paper and not always looking on the screen. I screenshot them and put them and copy paste them on the paper and print it out. Yeah. So all 3 cases are going to be E&M. And when you're looking at the first case, you want to ask yourself, where is this taking place? Okay? Ask yourself, because you remember we talked about, you need to determine location when you code for E&M, because when you get ready to look up a code, if you're going to look it up in your coding manual, you're going to go to your index and look up evaluation and management. And then you're going to need to know, where's all this happening? Is it in the emergency department? Is it in a physician office? Make sure you read your chapter, because there are some coding guidelines that affect how you're going to code it. And we couldn't go over all of that tonight, but you do know you need to ask that. And also ask, is this a new or an established patient? You remember we talked about that. And for the first case, that I'm talking about case 1 right now, you got 3. You only need 1 code, and it's going to be an E&M code. And what did I say your code should start with if it's an E&M? "99." Okay? Then, alright, so then in case 2, you're going to need 2 codes, and one of your codes is going to need a modifier. Okay? Now E&M has their own specific set of modifiers that you can use. So you need to go to your modifier chapter and look at that. What modifiers can be used with E&M code? But you're going to need 2 codes, and I want you to pay attention to what type of service this is. So this is not necessarily a location. You know, I talked to you about sometimes it's a specific type of service. So look at what type of service this is. Ask yourself, is a new or established patient? And then you're going to need a modifier, which is going to have to be, there's only a set of modifiers that you can use with E&M. So you're going to need to look at that, look at your coding guidelines, okay? And in case 3, you're going to need actually 3 codes, but let me tell you something. Sometimes you're going to have codes, 2 or 3 codes that may be the exact same code listed 3 or 4 times. Now, what I need to tell you is, so say if I have, I'm just going to make up a code. So if I have 35628, right, this code here, and for whatever reason, for my documentation, I need to list that 3 times. Now, I can either write it out, the code 3 times with commas separating them, or I can do it like this. And I'm not sure if everybody knows this is a shortcut way, which is the way I want you to use. Okay? 35628 times 3. Alright? Just want to put that out there because you might come across where you need to use the code multiple times to report on a case. So with this third case, you actually have 3 codes, but 2 of them are the same code, right? So you're going to do it times 2 for one of them, okay? And this one is not a particular, well, look at the type of service. It's in a location, but look at it, you know we talked about time can become a deciding factor. So think about that with case 3. Alright? And that's all I got. So case 1, you got 1 code. Case 2, you got 2 codes with a modifier. Case 3, you got 3 codes, but 2 of them are the same. I'm done because we've been in here since. Oh, I think it's been 2 hours. We gotta go. I'm so sorry. We will not do this long next time. But hopefully that was helpful. You're welcome. Welcome. Go get some rest. You're welcome. Help some of your classmates didn't come, so they may be confused about the cases this week. Good night.